Right. Hello, everyone, and welcome to this evening's webinar hosted by the PhysiQuip Academy. My name is Dominic Smith, and I am thrilled to be able to be joined by Paris Cai on this insightful session on the benefits and techniques of shockwave therapy in intermittent claudication. Thank you all for joining us this evening. Lovely weather we've been having recently. Hopefully you're all in air-conditioned rooms or at least have some form of ventilation because it's been quite warm recently. But in terms of this webinar, as I mentioned, it's part of the PhysiQuip Academy. If you've not come across the PhysiQuip Academy before, we're proud to offer a very diverse range of educational content with hundreds of webinars, podcasts. We're also developing workshops and courses as well. So if you haven't visited the website before, academy.physiquip.com, you can access it via the physiquip.com website as well. For those who've not come across PhysiQuip before, we're a medical technology company specializing in MSK rehab, offer solutions including diagnostic ultrasound, shockwave therapy, which we're talking about today, and exercise rehab, objective measures and testing. So as I mentioned, today we're joined by Paris Cai, who is an expert in the field, who's done some research on shockwave and intermittent claudication. It's going to start with a 20 minute or so presentation from Paris. For those who are joining us live, you have a Q&A function at the bottom of the screen. So any questions that you have at any point during the webinar, throw them in there and we can get those answered. For anybody who is watching back on the recorded session, any questions you have, submit them to info@physiquip.com and we'll endeavor to get those answered as well. So without further ado, Paris, I shall hand over to you and I'll let you crack on.
Fantastic. Well, thank you, Dominic and PhysiQuip, for the invite to talk about our research today. I'm Paris Cai. I'm one of the vascular surgery trainees in the Yorkshire and Humber region, and I've done research looking into extracorporeal shockwave as a novel treatment for intermittent claudication. I'll tell you a little bit more about this today. So I wanted to start off with a bit of a background, because we're dealing with people with intermittent claudication. And what is that really? It's essentially a similar disease process as you would have with coronary artery disease that can lead to things like angina or heart attacks, and things like cerebrovascular disease that can lead into stroke. The thing about lower limb peripheral arterial disease is that is not very much in the public eye. Not a lot of people know about this, even though globally it affects more than 200 million people. And in the UK, about 20% of people between the ages of 55 and 75 suffer with peripheral arterial disease. And I think about 5% of them would have symptoms of intermittent claudication. So as you can see here on the left of the screen, any part of the arteries that supply blood to your leg could be affected by peripheral arterial disease. And one of the most common sort of symptomatic presentations of that is intermittent claudication. And how does that present? It's usually pain in the muscle group that's affected by the reduction of blood supply, usually, again, the calves, and it's pain on exertion. Obviously, there is a lot of causes for pain in your calf on exertion, but if you have risk factors such as, older age group, diabetes, smoking, peripheral arterial disease should really be at the top of your differential list of what's the cause for this pain. Now, obviously, there is spectrums to the disease. And as you can see on the right of the screen, peripheral arterial disease could progress to what we call critical ischemia of the leg, where there's a high risk to sort of limb loss and life loss as well. And it is quite a significant disease, often under-recognized. But we're only focusing on people with intermittent claudication and how shockwave comes into play for them. Now, with regards to the management of intermittent claudication and what the evidence tells us at the moment is that people with non-life-limiting claudication, which means that the pain that they get in the calf is not stopping them or affecting them significantly in their day-to-day life, the best evidence out there will tell you that they benefit from supervised exercise and what we call best medical therapy. So that includes managing the risk factors such as smoking cessation, good diabetes control, hypertension control, as well as an antiplatelet, things like aspirin or clopidogrel, and high-dose statin. A lot of people think that, you know, when they come to sort of see vascular surgery for a peripheral arterial problem, that the only solution is to have an intervention. But actually, when you look at the evidence behind the intervention, you will get a very short-term or almost immediate improvement to your symptoms. But actually, when you look at the long-term data, there is no difference between having supervised exercise or having an intervention in your outcomes, which means quality of life and their actual walking distances. But the people who had an intervention then are sort of exposed to the additional risk of having a procedure, but also the complications that come to that with that, and the rate of re-intervention, which means having to go back and do more interventions to help. So really, the bulk of the evidence is with supervised exercise. How does ShockWave come into play? Especially if you look at the United Kingdom, there is very poor provision of supervised exercise programs for people who suffer with intermittent claudication. So a typical scenario on your average NHS hospital will be you see a vascular surgeon, you get diagnosed with peripheral arterial disease and intermittent claudication. The best medical therapy is implemented, but then there is no access to a supervised exercise program. So what you end up providing is exercise advice, which is suboptimal when compared to supervised exercise. So ShockWave could fill in a gap there where people don't have access to supervised exercise. How did we get about doing research in the first place for ShockWave in peripheral arterial disease? Well, it all started, as I'm sure most of your audience with PhysiQuip will know, there is an abundance of evidence for ShockWave in musculoskeletal disorders and, you know, wound healing, soft tissue injuries, bone healing as well. And they did notice that there was what we call a neovascularization effect with ShockWave, where smaller blood vessels would develop as a consequence of the ShockWave therapy. So then that was applied in sort of lab experiments with animals, but also in humans as well, firstly on coronary artery disease. And what they found was that patients who had no other choice with regards to their management of the coronary artery disease had improved perfusion and function of their myocardium. So it wasn't a very big leap to go from coronary artery disease to peripheral arterial disease in the lower limb. And again, in lab studies with animals, as well as small pilot studies in people with peripheral arterial disease, they found an improvement in their symptoms and their walking distance. So we took all of that and we designed a small pilot where we delivered ShockWave to the calf muscles of people with peripheral arterial disease with intermittent claudication specifically. And we split them into two groups. One group received the treatment and another group received the placebo treatment, which I'll go into a little bit in a bit. And what we found in this small pilot is that 12 weeks down the line, the group that had the active treatment with ShockWave had significantly higher walking distances. So that was used as a sort of base to create our big randomized trial, which is the sort of basis of my research. So what we did, we designed a double-blind, placebo-controlled randomized trial, and looking at which outcomes we would want to assess. If you look at most of the research done for peripheral arterial disease, people tend to focus on walking distances because it's the one and first thing that gets affected. But improving those doesn't necessarily confer an improvement in their quality of life. So we thought we'll focus more on quality of life and see whether we can improve patients' quality of life with a ShockWave treatment. So we used SF36, which is a well-established and validated quality of life questionnaire. And we used in particular one of its domains called physical function, which is the most impaired in intermittent claudication and the most responsive to successful treatment. Our inclusion criteria were quite simple. It will be patients with intermittent claudication and people who are already receiving best medical therapy and were either unable or were not willing to participate to a supervised exercise program. The exclusion criteria were obviously any contraindications to ShockWave. So we randomized our patients into two groups in a 1-to-1 ratio, so they were essentially equally split. And our intervention was for 3 weeks, 3 times per week. The active treatment group received 100 impulses per square centimeter in a 30 square centimeter area on each head of the gastrocnemius muscle, so the calf muscles essentially. And we used the piezo wave 2 system. The control group obviously underwent the exact same steps. We had the ultrasound gel applied to the calf. We applied the probe to the calf, but we never delivered the shockwave. So what we did, we used a portable MP3 audio speaker, which simulated the delivery of the shockwave, because anybody who has used the piezo wave 2 machine will know the characteristic clicking it does when you're using it. So we used that to simulate the delivery, and the patients were lying prone, obviously, to expose the calves and facing away from the machine. We followed them up at 4, 8, and 12 weeks after their first treatment. And as I said earlier, our primary outcome was physical function. We did, of course, measure walking distances as well as ankle brachial pressure indexes. So we randomized and recruited and randomized 138 patients, roughly equally split between the two groups, and we followed them up for 12 weeks. We had no adverse effects from the treatment. There weren't any patients who were unable to tolerate the treatment per se. There was one patient who had to withdraw from the trial because they had really severe COPD and they get very breathless when they were lying prone. So they had to withdraw from the trial, not because of the treatment per se, but the way that the treatment was delivered. Looking at the physical functioning score at 12 weeks, there is a significant difference in the intervention group, with them scoring a higher score in the physical function, showing essentially an improvement in quality of life 12 weeks after their first treatment. Something a little bit more tangible would be their walking distances. And you can see at baseline, there is no difference between the two groups, but after 12 weeks, there is a significant difference in both the pain-free, which is the walking distance. The patient can walk as soon as the first symptoms of intermittent claudication start, and the maximum is when they can no longer walk. And there was a significant difference for both of those between the intervention group and the control group. Also, the increase itself of the walking distance from baseline to 12 weeks was significantly different, again, between both groups. And what you can see here is actually, if you look at this graph, so both the pain-free and the maximum walking distance, the blue line would be the intervention group. There seems to be a trend of continuing improvement as the weeks went by, even though our treatment was only within the first 3 weeks. So even after the treatment was completed, there appeared to be a continuing increase in their walking distances. Obviously, I did mention ankle brachial pressure indexes. There was no difference between the two groups for that, but we weren't expecting any differences because we weren't targeting the arteries themselves, but we were targeting the muscles and improving the perfusion and function of the muscle instead. So, in conclusion, this is the first randomized trial looking at shockwave, extracorporeal shockwave therapy for intermittent claudication, recently published in the journal JAMA Surgery. And what does that tell us essentially for the future is that there is a role for this technology in the management of intermittent claudication, not yet to replace the current gold standard, which is supervised exercise, but if we can provide an additional treatment for people who do not have access to supervised exercise, where we can help them improve both their quality of life and their walking distances, I think it's definitely worth looking into and further research. Thank you very much. Any questions?
Wonderful. Thank you, Paris. It's really quite interesting. First and foremost, like, congratulations on getting it published and obviously being the first of its kind. It's I know it's a pretty big deal and lots of work go into these research papers. And I'd say it's quite actually refreshing, just as somebody who's read quite a lot of research on the MSK perspective, to looking at a new angle, a new area in that vascular side of things. I don't think there's very many that have done. Well, it's the only one of its kind. So there's not really many people that look in those areas. And it's nice to see, like, in my humble opinion, I'm not a researcher, but it's nice to see a well-designed study. I'm sure you've read plenty where you're probably scratching your head about some built-in biases and just the lack of outcome measure, decent outcome measure with some of the papers, I'm sure. So yeah, massive congratulations, obviously, to yourself and the team of getting that out there. In terms of, like, we've had some pre-submitted questions from those who couldn't make the event. You've actually answered some of the questions already in your presentation, but I'll go over them anyway and expand a little. I've written down some myself because I'm quite interested in this area myself personally. For those who are on live, as I've mentioned, Q&A function at the bottom. Don't be shy. I won't read out your name. I'll just ask the question. So I won't put anybody out there. But first and foremost, for Paris, obviously you mentioned about how it came about. For you personally, what was the draw to you looking at shockwave therapy for intermittent claudication, that specific indication?
Obviously part of my job is to see patients on a sort of almost day-to-day basis who suffer with peripheral arterial disease and intermittent claudication. And it's quite frustrating to be constantly reminded by the system that we are unable to provide the gold standard to everybody across the board who suffers with intermittent claudication. So that's the first one. Obviously, when you start reading about the history of shockwave, where it started from, the innovation that went into creating it in the first place, and how it started essentially from renal lithotrips, essentially breaking kidney stones, all the way to its modern uses now, as you see with yourselves as well, with musculoskeletal issues and wound healing as well. There's some really exciting stuff being done on wound healing as well with shockwave. So it was an excellent opportunity, and the sort of field was prime for this to happen, really.
No, I mean, it's really interesting. I mean, for somebody, I'm a sport and exercise therapist by background. So for those, and this is a question of somebody who pre-submitted, is for somebody who's not familiar with intermittent claudication, what are the biggest or the major signs and symptoms for this disease? And then what's the potential referral pathway for somebody picking this up? Because presumably, it's calf pain. I am willing to bet there's many people that have massaged intermittent claudication patients thinking it's just like calf strains or just general fascial tightness. So for you and your experience, and for those who might be seeing this in clinic, what are the big signs and symptoms that people should be looking out for?
So I would say probably your biggest sort of, in quotations, red flags will be the risk factors. So if you have someone that sort of ticks all the boxes for risk factors, things like I said, sort of older age, male gender is an independent risk factor as well. Smoking is the biggest one. So somebody who's either a current smoker or an ex-smoker, diabetes, obviously, and how well it's controlled, and hypertension as well.
Yeah.
If you see all these risk factors and someone describes, it's a classical sort of history, when I say classical, I mean its hallmark is reproducibility. So an MSK pain doesn't really behave the same as intermittent claudication. So the history you would get is somebody who could walk, let's say 100 meters, right? They'll get the pain, they'll stop. Within a few minutes, the pain goes away. And when they go back again to do it, it's another 100 meters, right?
Right.
Harder going uphill rather than on the flat or downhill. So if you're getting this sort of history and you have all these risk factors to alert you, then I would say have a high suspicion of peripheral arterial disease rather than a simple MSK problem. Now, obviously, as I'm sure you know, a proper history is pretty much 90% of the job. And if there's an obvious injury or there is an obvious sort of neurological cause for the lower limb pain, then that's a whole different story. But when things don't really add up, and again, from your experience, you would know true musculoskeletal pain and how it presents, and you have all those risk factors, have a high index of suspicion.
Sure.
And I would say if you have a high index of suspicion, a referral to vascular surgery wouldn't go amiss.
Right. Okay. And would that be the quickest way for the patients rather than going through GPs? I guess it's just like
I wouldn't be able to tell you about the sort of difference within each locality, but whether it's through the GP or what directly from yourselves, if you have a suspicion, it's easier to contact and maybe ask for advice or do a referral directly.
Right. Okay. And in terms of like, obviously, you can get the subjective history. From an objective standpoint, if you are suspecting peripheral arterial disease and intermittent claudication, those kinds of things, would a simple thing be if you've got a treadmill or if you've got an area where you can get somebody just walk backwards and forwards for probably all of about 2 minutes, I guess it would probably rear its head at that point. Are there any other kind of like objective tests that you do in clinic to do, and any diagnostic, or what are the diagnostic things that you do to identify the condition?
So I did mention ankle brachial pressure indexes. Obviously, it's a more specialized sort of examination. You need the appropriate equipment. But essentially, if you can think about it, it's like doing or taking the patient's blood pressure at the ankle, essentially. Right. So it's a blood pressure cuff around the lower leg. We use a handheld Doppler to listen to the sort of blood flow through the distal arteries in the foot. And then as you inflate the cuff, you know, it's the equivalent of doing the blood pressure in the arm, essentially. Right. And if in comparison to the blood pressure in the arm, that is low, then you have a higher index of suspicion of peripheral arterial disease. Now, there is a big proportion of the population who have peripheral arterial disease that actually have no symptoms at all, not even intermittent claudication. So you might be able to pick up a few of these people like that. But if someone is presenting already with symptoms, then you're more likely to have a positive test if it is true intermittent claudication. Now, as you said with the walking as well, there's the 6-minute walking test that you can do in clinic. If you have a treadmill, all the better. And if you can combine that with an ankle brachial pressure index, where you get the ankle brachial pressure index at rest, you get the patient to walk. When they get the symptoms, get them off the treadmill, do the ankle brachial pressure index again, and you will see a drop in the value because of the peripheral arterial disease. There's a higher demand of sort of oxygenation, of perfusion, which is not being met.
Right. Okay. No, that's really, really interesting. And I think for those people who are in clinic, I think it's just good that people know about this, because I bet there's plenty of physios, osteopaths, sports therapists that may have seen this in clinic. It might only be a handful of times, but may have seen this in clinic, because patients will go, oh, I've got calf problems. I've probably got a calf strain. I'll just go to the local physio and see if I can sort it out that way. I mean, even GPs and docs that are on the webinar have signed up. You know, it's worth knowing those things. In terms of the actual study, we've got a question coming in terms of like the outcomes, but just before we do that, we've had a couple of questions. You did go over it already, but just to clarify, one of the questions was how many total shots was the treatment that you did? Now you mentioned it was 100 shots per centimeter squared for 30 centimeters. So is it 3,000 shots per gastroc head?
Yeah, so a total of 6,000 for the leg at each treatment point.
Each leg?
Sorry, for the leg. We were treating one leg for each patient.
Right. And it was 6,000 shots. And you did that 3 times a week for 3 weeks?
Correct.
What energy levels were you using out of interest? Do you recall, like in terms of the millijoule per millimeter?
Oh, I have this number written somewhere. I don't remember it off the top of my head. If you let me stop sharing my screen for a second, I can get that for you.
Sure. If you just press stop share,
Yeah.
it should work. And find it.
Give me a second.
I've got you.
I will find this number for you. Absolutely. But if you want to ask me the next question while I find this.
I mean, one of the questions actually was going to be because of the amount of shots that you did. So, I mean, one of the questions was how many shots did you do and what was the treatment protocol? So you've answered that and we've clarified that with 6,000 shots on the leg. Now, 3 times a week for 3 weeks, on the general scheme of things, from an musculoskeletal perspective, right, that's a hell of a lot. That's a hell of a lot, even if you're using low energy, like 0.1 millijoules. Were there any side effects noted? Did you notice, for one? And I mean, was that taken into account in terms of that? And how did you get to that amount? Because generally in the research that it's usually like once a week and it's like 2,500 shots. So how did you get to that number?
So that was part of what we did in the pilot study, and we used the same sort of treatment that came from what was done before by other pilot studies, smaller pilot studies that were done from other people. It seemed to have been a safe protocol. It seemed to have been a well-tolerated protocol, so we applied the same. Right. Now, that's a very interesting question. We don't actually know what would be the optimal treatment. So how much energy to deliver, how often to do it, and whether it's once a week would be enough, twice a week, 3 times a week, or maybe to extend the treatment to 4 weeks or 5 weeks. We don't actually have these answers. And this is part of where the ongoing research will be really exciting, is to actually to see what would be the optimal treatment. And because we only followed up our patients up to 12 weeks, the other interesting part will be to see whether this effect actually continues for a longer time, whether we need to do a top-up session sort of a year down the line or 6 months. So these are all unanswered questions.
Which obviously, I mean, you're going to open those questions up when you're the first one doing the trial.
Absolutely.
So it's one of those, you're going to end up creating more questions than answers. Absolutely.
To answer the second part of your question as well, we didn't have any patients who couldn't tolerate the treatment.
Okay.
So from personal experience, because I have had shockwave for musculoskeletal issues, over bony prominences, it can be quite painful, especially at higher sort of energy doses. But because we were targeting a big muscle bulk, we didn't have anyone not being able to tolerate the treatment itself. And actually, we took pain scores from the patients on a visual analog scale from a 0 to 10. And actually, there was no difference between the group receiving the treatment and the group that were not receiving the treatment. So you can see how it was actually well tolerated. Like I said, there was only one patient who couldn't complete the treatment, but that had nothing to do with the treatment itself, but more that the patient was getting very breathless when lying prone to have this done. So just couldn't tolerate the process rather than the treatment, if you know what I mean.
Yeah, no, it makes sense. That makes sense. Have you got the energy levels?
I am scrolling through it right now. I'll get it to you in a second.
No worries.
Yeah, so it's 0.1 millijoules per millimeter per square centimeter.
So roughly total dose would be 0.1 times 3,000. So 300 joules of total energy per treatment. So 900 a week. It's quite high. But I suppose it's like the thing, it's just like, you don't know. I mean, I suppose that's where it could go in the future, isn't it? You could end up having a control group, one group that has 1 session a week, one group that has 3 sessions a week, comparing all sorts of different things. In terms of the results, we'll go into the results now. One of the questions has come through live. So you had an improvement in the walking, which was noticeable and interesting. for the data that you had, was that statistically significant? And also, did you know if there was a substantial improvement in the quality of life?
So, with regards to the walking distances, obviously the study was not powered to check significance for the walking distances. So you have to take this statistical test, obviously with a pinch of salt, but it was statistically significant for both the pain-free and the walking distance at 12 weeks. And actually, because we followed the patients up at 4 and 8 weeks, with regards to the pain-free walking distance, the intervention group, the group that received the treatment, actually had a statistically higher pain-free walking distance all the way from week 4. And for the maximum distance, there was a statistical difference from week 8 as well. So we saw statistical significant difference for the walking distances from as early as week 4 and week 8 after treatment.
Right.
With regards to our quality of life, for our primary outcome, we had a statistical significant difference in physical function, but actually, because we measured quality of life with a couple of tools, we had statistically significant difference in vitality as measured by the SF-36 questionnaire. We had a statistically significant difference in general health as measured by SF-36, and we actually had a statistically significant difference when we're using the EuroQol quality of life questionnaire as well. So there were quite a few other quality of life measures that showed a statistically significant difference from the intervention to the control group. But again, you take those with a pinch of salt because the study was powered for physical function only.
Right. Okay. No, good stuff. And another question that's come in, which is actually kind of tied into one of the other questions that we've actually pre-submitted, is given how ShockWave can be available at other areas besides hospitals, so obviously in the community, would you advocate or do you believe that this could become something that may be offered in the community through a multidisciplinary team approach? And the question that we had pre-submitted is who can deliver this treatment? So kind of double barrel, do you think it could end up in the community? And then who would be administering the treatment in your eyes?
That's an excellent question. So obviously, we're not suggesting that ShockWave is here to replace the evidence-based gold standard treatment that's already out there. So I just want to clarify that. But through sort of more studies that we hope to do in the future, if we do conclusively prove that this confers a benefit and also within a resource-limited NHS system, it's also cost-effective, then I could definitely see this treatment being out in the community. Because again, if you look at the supervised exercise research that's been done, one of the barriers for people or patients attending a supervised exercise program, other than the fact that the supervised exercise program isn't provided, is traveling to the location to have the treatment done. And if you can appreciate, a good proportion of this population is a little bit older. The commute to the center to have this done is a little bit more difficult. The cost of the transfer comes into play as well. And again, depending on which part of the country you come from, they might have to travel quite a significant distance to get to that tertiary center, that tertiary hospital that provides supervised exercise. So obviously, there is an attempt at the moment to expand the supervised exercise program within the community, but there's absolutely no reason why the same cannot be done for ShockWave in the future. And really, what you need to deliver this is somebody who is trained to deliver ShockWave, and that could be any healthcare professional, really, as it's already been done with musculoskeletal disorders. You don't necessarily need to be a doctor to deliver this, as long as you're appropriately trained to use the machine. And of course, as long as you have the appropriate diagnosis that your issue is intermittent claudication, and you may benefit from this treatment.
I think that's
And
interesting. I mean,
all you need really is a room and a sort of examination sort of couch for the patient to lie down on. So the consumables to deliver this would be, very, very cheap.
yeah, and I think it's a quick treatment. Actually, that's another question. What hertz would you put it on? What frequency was it on? Do you
It
remember?
was 5 hertz.
5 hertz.
Yeah.
Um, that's a pretty sort of standard. I mean, obviously you can go quicker. I think it's a flip of a coin. I don't think there's any with the hertz and how fast you deliver the treatment. In musculoskeletal world, we talk about if it's a lower frequency, tend to be looking at more tissue regeneration and cellular activation. The higher the frequency, you're talking north of 10 hertz, 10, 12 hertz kind of side of things, is more about barrage and pain modulation. Generally speaking, that's not, from what I've seen in the literature, there's nothing actually confirming that. That's just the general feeling, I'd
So,
say.
so dosing studies for shockwave is a big question, and hopefully we
Yeah.
can answer that in the future.
I mean, it'd be good to, I mean, this is kind of a little side thing, because from what I've read in the musculoskeletal world, and I get the sense that that kind of question may be unanswerable. And it's like standing on the North Pole and asking which way is north. I'm not, because people respond to mechanical, and that's the thing, it's mechanical input. People respond to mechanical input so differently. You look at exercise rehab programs or training programs, fast twitch fibers, slow twitch fibers, everything else in between, male, female, part of menstrual cycles, all sorts of inputs and variables. So I'm not a researcher, I'm not a physicist, I'm not a biologist by any stretch, but just from my simpleton perspective, I'm not sure that it's a question that can be 100% answered. I think we could certainly have ranges. I think there might be ranges, but I don't know. What are your thoughts? I mean, that's my thoughts on it. I mean, what are your thoughts on it?
Essentially, it's a guess, isn't it? Trying to see what works best. If you are to look into it and you are to design a trial to look into it, what doses would you use to compare with what? Really is, you know, and what we have, the protocol we have at the moment, we've shown it works. Okay, maybe a deviation to the frequency of the treatment rather than a deviation in the energy or the sort of the frequency of the sound waves being delivered might probably be and something that we can answer a little bit easier rather than, because if we start breaking it down into the energy, the exact area, maybe a wider area, maybe a smaller area, then we go down into a rabbit hole, which we, like you said, there won't be any light at the end.
I just really don't think there will be. And I think when you look at, I tend to compare just from a simpleton perspective, shockwave energy input, like the weights that you do in the gym, is that so the energy input, whether it's 0.1 millijoules, 0.3 millijoules, whatever that might be, it's like the load that you put on a squat rack. And everything's so individualized. If I put 100 kilos on a squat rack, not everybody can do that. Some people would just crash and burn. Some people think that's a doddle. And I think it's like, if you then did a study that said like, I don't know, control versus just body weight squat versus 100 kilo squats, 3 reps, 3 sets, 10 reps, and so loads of people fail at it, or it's not the optimal weight for that individual, and they conclude the squat rack's no good. It's like, well, not quite. If you change the question slightly, where you say it's going to be 60% of a 1 rep max, and you're going to do 3 sets, 10 reps, you're going to have lots of different loads on that squat rack, on that bar, but everything's also personalized to each patient that goes through. And I think for me, that's where I sit on the energy input, is that what we do with professional athletes is entirely different to what you're going to be doing in the vascular world. Because tissue load, I mean, these pro athletes, they're putting their bodies through so much load, they can tolerate quite a lot more. And it's like, actually, the guidelines kind of go out the window with athletes in many respects. There might be some people who watch this back. I mean, that's another rabbit hole. But I'll go on to the other questions. Just to confirm for Anil, who asked about the dosage again. So it was 100 shots per 1 centimeter squared over a 30 centimeter square area. Yes.
Right. Yeah.
300. Oh, sorry. So that would work out as 3,000 shots per gastroc head
Yes.
at 0.1 millijoules per millimeter squared.
Correct.
So a total of 300 joules per gastroc head at 5 hertz. And then that was 3 times a week for 3 weeks.
Correct.
Perfect. Good memory.
So that's the other thing as well. Most supervised exercise programs are for about 12 weeks.
Right.
Usually either 2 or 3 times a week, and the program itself will last for about an hour.
Yeah.
So what we're suggesting with ShockWave as well is we're delivering a treatment at a much shorter interval for a lot less time. Yes, you know, if you work it out with the hertz, you'll find it's probably about 20, 25 minutes to deliver this treatment. So it's about a quarter of the time for each session, and a third of the, well, a fourth actually of the overall treatment time.
Yeah. And I think, I mean, when you actually look at it, if you were to do 5 hertz for 6,000 shots, that would probably take, about 10, 12 minutes probably. If you were to do that at 10 or 12 hertz, I mean, it'll be about 6 minutes. So again, it's like, you know, people tend to whack the hertz up sometimes, whack the frequency up if they're short on time, just get through treatment. In terms of the outcomes, so we've kind of touched on that already in terms of the improvements. Now, there is an improvement in both groups. So 2 questions. One is my question off the back of this, and then one was a pre-submitted one. Is so we saw an improvement in both groups. So that's one that's interesting. So why do you think there was an improvement in both groups? The second part to the question, which is the pre-submitted one, was if there was an improvement with the ShockWave group, why do you think that is? Do you think there's a biological response going on? Do you think it's a pain modulation side of things? So yeah, it was interesting that both improved. So why do you think that happened? And then what do you think is happening with ShockWave to get the improvement?
So for the first part of your question, we were expecting to see an improvement in both groups because if you look at the literature, essentially by going on best medical therapy, by managing all the risk factors and smoking cessation as well, that in itself would improve your walking distance. Okay, so we were applying all of that to both groups. So we were expecting both groups to improve. Now, there's also an effect on people who participate in research. They tend to try and do a little bit better because they're being assessed as part of a treatment program. We had more people deciding to give up smoking as a consequence as well. And again, I don't know if it's because they were seeing me 3 times a week for 3 weeks, where I would constantly remind them, you need to stop smoking. You need to be taking all your medication as normal and try and walk as much as you can. So there's a lot of reasons why we would see an improvement in both groups. The important thing is that despite both groups improving, the intervention group still did significantly better.
Right.
That essentially the only explanation would then be the effects of the shockwave. Now, with regards to why do we think there is an improvement with regards to shockwave, is this theory of neovascularization. So if you think about your arteries essentially as pipes, if there's a narrowing or a blockage, there's less blood going down. Now, it's a chronic process, so the body itself is wonderful in a way to create sort of what we call collateral circulation. The body itself will create new, smaller blood vessels to try and go around the blockage itself to provide as much blood down to the leg. And again, if you like to think about it in a bit of a simple term, is like, you know, you're going down the motorway and there is an accident, you'll go around the B roads to try and get around it to get to where you need to get.
Yeah.
Now, with the shockwave, the effects of shockwave that was shown in sort of laboratory studies with animals is that it induces this neovascularization effect, and there's a formation of new blood vessels. So by doing that to the calf muscle itself, the already established sort of collaterals by the body, or whatever little or less, I should say, blood that was going down there, gets to be distributed a little bit better within the calf muscle. And as shown by our colleagues who've done the research in sort of coronary artery disease around the heart, they did show an improvement in sort of myocardial perfusion and function as well. So we'd expect the same effect within the sort of gastrocnemius muscle or the calf muscles entirely. Now, within animal studies, they've actually managed to demonstrate these new blood vessels, but we haven't been able to demonstrate that with humans. Within our study, we haven't particularly checked, but other studies that looked at doing shockwave in people with intermittent claudication, they haven't been able to sort of radiologically demonstrate these new blood vessels the same way they've done within animals. And as you said, with regards to the sort of neurological modulation as well, there is a theory that the way it works is by stunning the nerves, and then the patient, as a consequence, experiences less pain. And they try to test that theory in animal models, but actually the neovascularization effect was so big, they couldn't conclusively answer the question whether it was actually neural stunning that was causing this. So yes, these are all sort of working theories as to what happened. And again, when we're talking about future sort of research, what we call a mechanism of action study is also another interesting part, to actually have a closer look at how this might be working within the sort of human body.
Yeah, I think it's a really interesting space, because I know there's a lot of stuff that have been done, like sort of is it in vitro, outside the body? Yeah, that have shown some things, but then I know there's a lot of animal studies which people take a pinch of salt out of, but when you see the volume of studies that have been done that are showing consistent responses, it's like, well, there's got to be something going on here in these tissues. In terms of like with shockwave, how, and with the current management of intermittent claudication, so the gold standard being the exercise programs, let's say that shockwave becomes like it needs to be done. How do you see it being integrated into practice? It kind of ties into the question we had a little bit before about the going into the community, but from your view, where do you think it fits in the treatment pathway?
Yeah. So, again, it's the thing about exercise, it has a lot of collateral benefits as well. There's the cardiorespiratory benefit as well, which you will not be able to match with shockwave. So what we're hoping, or what basically what my sort of hope is that until everyone can have access to supervised exercise, which would be the gold standard, then what shockwave could be, it could be an intermediary step, because some of these people suffer quite significantly with intermittent claudication. And if we can improve their walking distances, if we can improve the quality of life, then maybe they themselves can feel a little bit more confident to engage in exercise. Because unfortunately, there is the misconception that you walk, you get the pain in the calf. If you continue to walk, you're going to cause damage to your leg. While actually what we want is people with intermittent claudication, when they are exercising, is to try and walk and push to the point where they physically can't do anymore, because that helps improve your sort of collateralization down the leg, and as a consequence, improve your walking distances. So if we can give people without access to supervised exercise that intermediate step where they can walk a little bit more, where we can show an improvement in their quality of life, I think it's definitely worth doing.
Sure. And that's an interesting point, actually, because if you're saying that they're in pain, so from the perspective they get the pain, they're okay to keep walking, obviously, not to the point where it's like unbearable, but if it's manageable and the patient can push through, they're not doing any damage.
No.
It's just basically the muscles just kind of like, I'm not getting enough oxygen, give me some more oxygen. And I suppose, though, it kind of makes sense when you think about it, is the muscles are then saying, I'm not getting enough oxygen. That's telling the brain, I'm not getting enough oxygen. So the brain then goes, well, I need to stimulate something to improve the blood flow down there. And in theory, then the body should naturally produce more blood vessels. Is that the kind of theory by pushing through?
The collaterals that you develop as a consequence will never be able to replace the original plumbing.
Right.
Will never be as good. But just by walking and trying to push yourself, patients do find that gradually their walking distance does improve. So
it's really interesting because I mean I'm sure there'll be many people be like, no, if it hurts, stop. So I mean, I guess that's again, it's a challenge that you face when treating intermittent claudication, is that people, I presume, will become just more sedentary, which just puts people into that spiral, I guess, of just like that's problematic, really. I know we'll wrap up with the last question. You've touched on in terms of future applications of this area and where things could go. I think it's definitely worth asking this question of because it's the first study of its kind. So what other studies have you got in the pipeline, if any? And where do you think the future of this line of study will go? And what do you think other applications that might be available for shockwave therapy in this space?
So again, this is entirely for me. I would say the next step will be to try and see how it compares with exercise, because exercise is the gold standard at the moment. And then if you can look in a parallel way, I guess, like we said, in dosing studies, or maybe even in a top-up study, like I said earlier, if we look at maybe the long-term data, maybe there's a plateau in this increase in your walking distance, and maybe in 6 months' time or a year's time, you need a top-up treatment. These are all the little questions that need to be answered. But I think the biggest one that would sort of propel this more into practice would be a comparison with supervised exercise.
Wonderful. No, I think that sums it up really nicely, Paris, really nicely. So look, we'll close up for the evening so we can actually like put our feet up now and try and cool down. So for all the people that have joined us live, thank you very much for joining us and spending the time with us this evening. Personally, Paris, I found it really, really interesting. I think it's a different space, and I love learning about these kind of new areas. And I really hope for the people that have been on the live session, but also the people recording it, watching the recording, should I say, have just found this as enlightening and as formative as I have done as well. Clearly, it's going to open up more questions and I think answers, but that's the whole point of these kinds of research. And once again, I throw out my congratulations to you guys getting this paper done. Obviously, I think the original conversation I had was with George Smith, and then everything's kind of gone from there. And it's great to work with you guys at Hull University. For those who are watching as well, remember, the learning doesn't necessarily stop here. Don't forget about the PhysiQuip Academy. There are hundreds more webinars and podcasts on that site, so you can continue expanding your knowledge, not just in shockwave, but diagnostic elements, exercise rehab, and some other specialist areas as well. Do keep an eye out for any upcoming in-person courses and workshops. We'll give you the opportunity to get hands-on with these technologies as well, so you can upskill and learn. And then again, for those who've participated live, thank you very much for your questions and the engagement in the session. If you have any further questions or need clarification on anything that we've discussed this evening, then do not hesitate. Give us a contact on info@physiequip.com. You can always revisit the webinar, as we'll be sending it out as a recording for you to watch back, and it'll be available on our Academy site as well. But yeah, listen, thank you once again for your participation. And we look forward to joining you at more future events. For anybody as well, who've got any further suggestions for Paris, if you want to do a follow-up one around this area on the vascular side of things, then again, contact us, let us know. Your feedback's really valuable. We want to deliver what you want to learn about. So do keep us up to date. Until then, everybody, keep learning. Have a fantastic evening. Paris, thank you so much for your time and your expertise.
For the invite, Dominic.
And have a lovely evening.
Thank you.
All right, take care.